Okay, let's get started with the glutes. So first of all, obviously the glutes are a common nickname. The long formal name is gluteal muscles. A lot of times when people talk about the glutes, like it's very common for people, whether they're working out at the gym or they do yoga or many different sports and many different ways of getting in shape. People are very interested in making sure they're working out their glutes. And as far as like, you know, just working out at the gym, doing squats, whatever, a lot of people tend to be most aware of Gluteus Maximus. But there's actually 3 glutes, and Gluteus Maximus is the big superficial one that takes up the whole area, and then Gluteus Medius and Gluteus Minimus, which are both deeper and smaller, but also both important. So there's 3 glutes, and like the neck, you know, the cervical area, but for different reasons, this is an area that a lot of new massage therapists, particularly students, get a little nervous about this area at first. And I think that studying the kinesiology and the anatomy of the area will actually help you get more comfortable, because you'll have like this really clear picture in your mind of how exactly the muscles are going and where they attach, so you can be very clinical in your approach, whether you're working through the sheets or through underwear or directly on the skin. Does that bring up questions so far? Pardon me, the Zoom picture was in the way. Can you see that PowerPoint picture nice and big?
Yes.
Thank you. Okay, so as you know, I love this view of the picture in Trail Guide, where they show the origins and insertions shaded in gray and red. So this is a really nice view of where you can see Gluteus Maximus attaching on this whole lateral border of the sacrum region all the way up to this part of the iliac crest. Medius attaching in this entire region below the iliac crest, and then Minimus's attachment is quite deep, and this is the hardest one to specifically isolate, but you could still work it through the other glutes. And then here's a nice picture in red of where these muscles insert. So I just want to call your attention and see how quickly I can pull out an annotator. Hopefully something bright that you can see here, that we've already, all the way from the 2nd week of school in our compression unit, you know, been really talking about really focusing on this lateral border of the sacrum. And you can see how Maximus attaches there, Gluteus Maximus. And how we've also been focusing, especially as we got deeper into Swedish massage, on how it's very important to work the whole border of the iliac crest from below or inferior, as well as from above. So when you come up at this iliac crest, from just below the ridge is where you can really focus on Gluteus Medius. Questions so far? All right. Whoops. My drawing tool is still on. Ha ha ha. Clear all drawings. There we go. Whoops. Sorry. These annotators are a little clumsy. Okay. All right, so let's start getting into the details of origin, insertion, and action with Gluteus Maximus. And speaking of OIA, I know you guys like to go into breakout rooms and practice OIA. And the only reason we didn't last week is because we didn't have enough muscles yet. And so now that we're adding more muscles, we'll be able to review in that way or study in that way together. All right, so everybody has heard of Gluteus Maximus and probably done some specific workout or exercises or training to work out their glutes. What are your favorite exercises to work out your glutes? You can call it out or write in the chat. What do you do to train your glutes? I know you all do some things.
Squats.
Yep, thank you. Squats are great for the glutes. Somebody wrote something in the chat. Deadlifts, thank you. Squats, lunges, thank you. Great. And hills are great for the glutes. So if you do hill training or stair training of any type, or stair climbers, things like that, also good for the glutes. There's more coming up in the chats. Hip extension, thank you, Cesar. All right, so let's look at Gluteus Maximus. Gluteus Maximus, I like to start with O and then I, because then the action makes more sense. So the origin, I already focused on that, I'm gonna use a better color that stands out. I already called out that part on the edge of the sacrum, but let's go through the whole thing. So starting at the coccyx, way down here. Now, I always like to help make massage connections for you. As you probably know, the coccyx can be a vulnerable bone. And so this is one where we're not going to focus so much right there on the coccyx. This is, people call it the tailbone. And this is one that you probably, either this has happened to yourself or somebody who it's happened to. If you take a bad fall, this can even, subluxate or dislocate your coccyx. But this is a vulnerable area and a vulnerable bone, so we're not massaging right there so much. Questions so far? Or does anybody have any personal or clinical experience that they'd like to share around the coccyx? Okay, edge of the sacrum. Hopefully you guys are getting a pretty good sense that this is super palpable. So you really want to get all the way along this edge of the sacrum. And this is one of those areas where you really want to take your time, and the better your palpation skills are. Like, I don't know if you've noticed it yourself or maybe noticed it more in your classmates, but your palpation skills are already a lot more advanced than they were at the beginning of first quarter. And so now, when you really go along that edge of the sacrum, you should be able to feel where you feel tight ropey bands, which literally sometimes will feel like a tight ropey band, or sometimes you'll just feel like a more dense or harder area. So some of these fibers, and fascia can be tighter than others. So you really want to warm up and work the entire area and slow down where it's tight. Now that we're going to learn MFR, you can add MFR to your repertoire of how you work it out. Compression, prolonged ischemic compression is nice, being nice and slow there. You can use heat to warm it up, and you can also use your linear or cross fiber friction. Working our way around even to this aspect of the posterior iliac crest. So this entire long attachment, as well as the sacrotuberous and sacroiliac ligaments. Now, for massage licensing exam purposes, I just want to call to your attention that they will sometimes use shorthand description for location of muscle or origin and insertion of muscle. So what we have right here is a very detailed description of the entire length of the origin. But if there was, say, a test question that just said what muscle originates on the lateral border of the sacrum, even if they don't list the entire long thing, you could still know that the best, answer would be the Gluteus Maximus. All right, and so then moving on to our insertion, we have our iliotibial tract. So the upper portion up here, and you can see that beautiful gray line of fascia, as well as the gluteal tuberosity of the lower fibers down here. So Sharice and I were talking in a Zoom the other day together with you all about the type of connective tissue being a different type of tissue of this ITB than the muscle tissue that has all of those muscle fibers pulling to contract it. So, and I was talking about, I introduced the concept to you about when you release a tight ITB, one of the things you want to do besides separating the tight muscles that it's stuck to, like if it gets stuck to vastus lateralis underneath it, you can separate it. But in addition, what you want to do is release or lengthen the muscles that are pulling on it to make it too tight. So Gluteus Maximus is one of those muscles that originates or inserts into the ITB. And so if your ITB is tight, which is super common, you're going to see a lot of clients have a tight IT band. One of the things that you can do that's very effective is to make sure you work the muscles that pull on the IT band. And we're going to look next week at one that pulls from the front, tensor fascia lata, or latte. Questions so far? Okay, so working the origins insertions for most muscles is a very good strategy. In really large muscles like the Gluteus Maximus, it's, I would say, a necessary strategy because the Gluteus Maximus is such a large muscle. Sometimes you get even better release, making sure you work out that origin and insertion. Now, that's not to say you avoid the muscle belly, because you definitely want to warm up the muscle belly as well and get into that tissue, but definitely release the origin insertion. You'll have some clients where their Gluteus Maximus and their other glutes and deep six, are so big and strong and tight that it's literally hard or impossible for you to get enough pressure in there. So after a good warm up, you'll have better effect with the origin insertion. All right, so you can see how these muscle fibers go swooping down from that origin to insertion. And this inferior portion, makes up this inferior border of the gluteal area. And our actions are A. The Gluteus Maximus extends the hip and laterally rotates the hip, and abducts the hip. And the lower fibers can adduct the hip. So in this action of abduction away from the body and adduction towards the body, in that particular action, Gluteus Maximus is an antagonist to itself. The glutes are a very strong extender of the hips. And let's take a moment, look at the lateral rotation aspect, because from posterior, we're pulling on the femur, means that we can really turn it out this way. Questions on the actions? All right, let's take a look at the next glutes. There's only 3 of them. I think it's a relatively easy group of muscles to learn and massage and understand. This is a beautiful diagram that shows you in relationship to each other, if you were to cut away gluteus medius, which is superficial to gluteus minimus, it shows you a good reference for exactly how much of that area is taken up by minimus compared with medius. So we're now going to focus on minimus, which is the deepest of the three glutes and the hardest to isolate. The gluteus medius, which is pictured right here, originates on the gluteal surface of the ilium between the anterior and inferior gluteal lines. And we talked about those lines when we first studied the hip, but as a review, those are very deep lines and they're not anything that you would palpate. But if you were doing a dissection or looking at a model, they would be sort of roughened lines. But you're not gonna palpate them that deep through the other muscles. The gluteus minimus inserts on the anterior aspect of the greater trochanter. And I think that's a really great example. I'm just looking for a good picture of it here on page 316 if you're following along. I think that's a good example to really call out, as will be true of the lateral rotators of the hip as well, how right from the beginning of class, right from the second week of class, we talked about when you massage around this greater trochanter, you really want to massage all the way around it. And it's super palpable. On many people, it's as big as a fist. I mean, it's a really big bony prominence. And rather than just like, oh, okay, I feel the bone and now I'm going to shove my elbow behind it, right? Rather than just doing that, you really want to make sure you work all the way around it because of the different muscle attachments. And here we can see that the gluteus minimus actually attaches around the front. And just as a review, and of course we'll have more labs with this as well, but this is one of those techniques where you can bend the knee and put a fist or an elbow or some other tool in that greater trochanter, and then really medially and laterally rotate the hips by moving that foot medially and laterally, really using that as a hinge. And you can use that as a pin and stretch to really get in there. Are there questions so far? All right, so because the gluteus minimus reaches around to the anterior aspect, it's actually able to do some flexion of the hip as well as some medial rotation of the hip. And I would say, this one tends to be sort of overridden by the lateral rotators. It's much more common to have overly tight lateral rotators than the medial rotators. And a clinical example that I'm sure many of you noticed on the massage table is that a lot of clients, if they just relax on the table, their feet will flop really far out laterally. This lateral floppy foot rotation can come from different places. It could be more from their ankle, it could be more from their knee, but in a lot of cases, that rotation comes all the way up from the hips. And so if it's in somebody's, their relaxed position is to be so far laterally rotated, their lateral rotators, that's a sign that their lateral rotators are too short and tight, including this, focusing on the glutes. And then next we'll look at the lateral rotators. So the other actions are abduct the hip. It's a strong abductor because it comes over the top of the hip. It can pull that hip up and out. It medially rotates and flexes the hip. Any questions on that one? Okay, last one. Gluteus medius. So Gluteus medius is oftentimes compared to the deltoid of the hips because it has a the way that it attaches. If you look at your models, you can see if it comes all the way to the front of the iliac crest, all the way back here, it's actually wrapping around the front, the side, and the back, just like the deltoids have wrapping all the way around the front, the side, and the back. And so because of that, just like the deltoid, the part that's in the front, the anterior part, can do more of a flexion and a medial rotation. The part from the side, and actually all the parts, can abduct or pull to the out and up. And then the part that attaches in the back can do a lateral rotation and an extension. So in that way of attaching in these different angles, like the deltoids, it also ends up being an antagonist to itself. Are there any questions on that? Does that make sense? Can you picture that? When you sculpt it today, and I'll sculpt with you, really take a look at that of what a broad origin that is and how it crosses from the front, the side, and the back. All right, so breaking it down. Origin, gluteal surface of the ilium between the posterior and anterior gluteal lines. And again, we looked at this picture before, but on page 316 is a great view to really see how much of that surface medius attaches to. If I could outline it, estimate an outline, it's about that much of the bone. So really a big surface of the bone that it originates on. And all the way right up to, just below the iliac crest. And that's super palpable. So clinical application, when I talk about massaging right up from the muscles that come from the below the iliac crest, the glutes, as well as the muscles that come from above the iliac crest, this is something that you could definitely palpate. So you want to go as close to that ridge to where you really feel the muscular tissue, and it's very palpable. And then the insertion is the lateral aspect of the greater trochanter. And again, your trail guide has a great picture on page 316 that really shows exactly where that insertion is. And then the actions, all the fibers, the anterior, the medial, and the posterior, all abduct the hip. So bringing it out and away from the body is abduct. Flexing the hip would be the anterior fibers. If it attaches from the front, brings them forward and medially rotates. I'm showing you on my shoulder because it's the same ball and socket joint that has the same type of movements, because I can't really show you on my hip. And this one won't allow me to go out too far into abduction, but abduction, flexion, medial rotation, bringing the hip in, posterior fibers, extension, and lateral rotation. So any questions about medius? So to bring it back to massage, and now that we've looked at all three of them, let me just clear these annotations. Bringing it back to massage, parts that are super palpable for all three of these is to follow all the way from the lateral border of the sacrum. Remember, we're not going to focus on the coccyx because that's too vulnerable. As far as the origin insertion, all the way below the iliac crest, all the way to the front of it, and then around the greater trochanter, the posterior aspect all the way to the anterior aspect, the lateral aspect, and all the way to where that tissue goes into the IT band, and then all the way down to here. So really that's tracing all the way around the origins and insertions, but then we can massage the muscle bellies directly themselves. So any questions on the glutes?
Yeah, you mentioned we're going to avoid the coccyx because it's too vulnerable. To clarify, do you mean that because it's close to like the gluteal cleft that we're trying to avoid, or is it because it's easily breakable, or is it just a combination of the two?
That's a great I can talk. That's a great clarifying question, Jordan, and it is actually both. It is close to the gluteal cleft and anus that we're avoiding. It can feel sexually vulnerable. And also, it is actually quite easy to, subluxate that bone, and or if it's already kind of out of alignment, which it is for many people. Sorry, my cat knows it's not supposed to be there, but she knows she can also get attention if she does that. Sorry about that. And so especially we're not, just pressing like we would along the border of the sacrum with, say, a bigger tool like an elbow, but somebody who really has the palpation skills and the clinical skills, like a chiropractor, for example, would actually work, if there was a coccygeal subluxation, they could actually work to get that in place. But we're avoiding that. Does that answer your question?
It did, thank you.
You're welcome. Are there any other questions at all about gluteal muscles and or clinical applications of palpation or massage? Okay, well, let's move on then. And then, of course, we'll have labs that include massage of this area. So that will, of course, clarify your understanding when we get to that. I know we've had other labs where people have already been asking questions like, about working those areas directly and if on the skin and so forth. So we'll get back to that in lab. All right, so the deep 6 lateral rotators of the hip. And if anyone gets there faster than me, could we have a shout out on our page number in our book? Here we are, page 328. We have our deep 6 rotators. So these topographical views are kind of nice, just as a kind of a sort of a reminder, looking directly at the skin where these various landmarks are. We're pretty familiar with this at this point. And a review of the hips, and we'll be looking at some of these attachments specifically related to the deep 6 here in a minute. Pardon me for the scrolling. So this is an interesting view. I would say that the deep 6 rotators are one of the most confusing muscles as far as the 3-dimensionality of how they, wrap around corners and dive through tunnels. But I also want to call out that there's only 2 of them that are more specifically isolatable or palpable. You can work with them as a group, especially, around this greater trochanter, a lot of the details of how they dive or go internal, we can't massage anyway. But the two that we can palpate the most specifically, and so they're the most clinically relevant, are Piriformis and Quadratus Femoris. Now there's 6 deep lateral rotators of the hip, and it would be a common test question to know all 6, but the 2 that are most important massage-wise are Piriformis and Quadratus Femoris, which are both clinically very important. And Piriformis is so important that it can even cause what a lot of people think of as sciatica. So a lot of people will say they have sciatica if they have any of the type of pain of sciatica, including the pain in the butt or gluteal region, and whether or not it radiates down the back of the leg or the side of the leg. And a lot of people will say right away, oh, I have sciatica. Well, true sciatica is actually an impingement of the sciatic nerve. But there's what's called a pseudo-sciatica, or piriformis syndrome, where this piriformis muscle is actually pressing on the sciatic nerve. And it can cause the same symptoms. But the nice thing is, when people have piriformis syndrome, which is very common, it's often very treatable by massage. And in our injury evaluation and treatment class, we will do specific protocol around piriformis syndrome because it's such a common issue. Does that bring up questions so far? Oops. Okay. So many of you may recognize this picture from the, sorry, I'm just trying to clear that random pink line on the screen. Many of you will recognize this picture from the Synergist pages. I think the Synergist pages are super valuable to study. They take every movement of the body one by one and highlight which muscles can do that movement. From the order that they're listed in is actually the strongest performer of that movement down to the weakest performer of that movement. And in these Synergist pages, they also make the movers of that movement in a darker red. So it gives you a good visual to help you really put together those movements. Because when we first start studying the muscles and the movements, as almost everybody who studies kinesiology, at least in massage school, the common way to do it is to first study the muscles individually. But then in your clinical practice, it's very important to start thinking about what are all the muscles that do that movement, right? If you see, for example, that a client's laying on the table and their foot is turned out and it looks like it's coming from their hip, and you're like, oh, okay, the lateral rotators of the hip are probably short and tight. So then you want to have in your mind, well, what are all the muscles that do that movement? And then for clinical applications, it's also useful to think about the antagonists of that movement. For techniques like muscle energy techniques, like reciprocal inhibition, and we'll get into those soon. So here we have our deep 6 rotators, Gluteus Maximus. Here's our deep 6. We'll go by them in name really soon, as well as our psoas, iliopsoas, psoas major, iliacus, that'll be next week, along with sartorius, and then even a bit of biceps femoris, which we did last week. So questions so far? All right, by the way, we're making really good time. We are almost done with today's muscles, just in time for lunch. Okay, so this is a nice view of most of the deep 6, excuse me. with the gluteal muscles removed. So the glutes would be superficial to these muscles. And so these are deep muscles. We call them the deep six is their nickname, because they're the 6 deep muscles that laterally rotate the hip. And so here we have piriformis. I mentioned that piriformis and quadratus femoris were the 2 that are most easy to isolate and palpate. And then here you can see the sciatic nerve emerging from under piriformis. And this is why the piriformis muscle can so easily compress the sciatic nerve, because it emerges right there underneath it. And in fact, due to anatomical variation, there's differences in all ways, with the even the origins and insertions and exact muscles, how they play out in the body. But one anatomical variation is that sciatic nerve can even go through the piriformis muscle. So it can either go under it or actually through it, and it can get compressed. Now, something interesting about the sciatic nerve, because we haven't really done any dissections, although I share with you dissection videos, this sciatic nerve is about as thick as a pencil. So it's a really significant nerve bundle innervating the leg. Questions so far? All right, well, let's break these down one at a time. So this is a great slide because it highlights the 2 that are, most palpable. So let's start with piriformis, and I like to start with the origin. So the piriformis originates on the anterior surface of the sacrum. This very lateral border of the sacrum, where Gluteus Maximus attaches, it actually wraps around the front of it. And while it actually wraps around the front of it, or the anterior aspect of it, it is still very useful to really focus on that lateral border, even though it wraps around the front. So you can't actually reach all the way to the exact attachment, but it's still useful to massage there. And it inserts on the superior aspect of the greater trochanter. So once again, just proof again that these muscles attach all the way around the greater trochanter. And so when you're massaging it, you really want to massage all the way around. The piriformis, moving on to actions now, is a very strong lateral rotator of the hip. And when the hip is flexed, it can also abduct the hip. In other words, bringing it up and out away from the body. Now, many people have a tight piriformis. I'm just going to go over a little palpation tip here, and we'll practice this in lab, of course. But there's a great trigger point here on piriformis that's super palpable, and I'm going to try to highlight it right now in orange. And how to find that trigger point is if you put your fist on the greater trochanter and then went about a thumb width up into the glutes. That's about how far in it is. And it's very palpable, and we'll massage that. We'll get to that in trigger points very shortly. Many people have a tight piriformis muscle. I would say it is as common as a tight iliotibial band, and that can happen whether somebody is super athletic, like I've seen it in a lot of dancers, and it can also be very common in people who are very sedentary and or have desk jobs. All right, so quadratus femoris. You guys know another quadratus, or excuse me, another femoris. The femoris is referencing attaching to the femur. The quadratus femoris Let's start with origin. O is the lateral border of the ischial tuberosity. What else do we know that originates on the ischial tuberosity? What other muscle originates on, it's a whole muscle group, originates on the ischial tuberosity? I know you know it. I'm going to give you time to take off.
The hamstrings.
Thank you. I know it takes a while to get off your mute. I appreciate you chiming in. So the hamstrings. So I am now coloring in purple, again, that the hamstrings have this very large attachment to the ischial tuberosity, each hamstring in its own aspect. And then Quadratus Femoris, more lateral on the border. And so again, I mentioned this during our hamstring lecture. A lot of massage therapists, if they're not super knowledgeable in kinesiology, will just take an elbow and just shove it under the bottom of the ischial tuberosity. And that can be helpful. But now you guys know that the ischial tuberosity and the beautiful muscles that attach to it are a very large attachment, and it's useful to work your way around. And so this is a great place to isolate Quadratus femoris here out on the lateral aspect. And then our insertion is intertrochanteric crest between the greater and lesser trochanters. And so you would come medially to the greater trochanter for this. And then the action is laterally rotate the hip. All the lateral rotators, that is the action that they have in common. So they are all synergists in lateral rotation of the hip. And are there questions so far? Okay. So now for these next muscles, they are more complicated to understand three-dimensionally and harder to palpate. And if you haven't already watched the dissection video, I think it's very useful to show you how they actually go around the corners and so forth, because it's hard to picture in this two-dimensional space. So I think actually I'll cue that video, and when we come back from our lunch break, we'll go over that part of the video so that I think it'll help give you a more clear understanding of what's going on with these particular muscles before we start to sculpt them in clay. But here we go. We have Obturator Internist and Obturator Externus. They all laterally rotate the hip. And what they're referring to in terms of what is internus, like internal, and what is externus, like external, is whether it originates on the outside or inside of this obturator membrane, or this big hole here on the hip. So let's start with internus. It originates on the interior surface of the obturator membrane. So on the inside of this big hole or circle of the hip. And it inserts on the medial, and obviously we're not massaging there, right? And then it inserts on the medial surface of the greater trochanter. Now, I would say you're not going to be able to specifically isolate the exact spot it attaches, but that it is useful to work your way around and to massage the tight spots. And then it laterally rotates the hip. And then our externus, it originates on the outside of the obturator membrane. So on the outside of this big hole of the hip, as well as the rami of the pubis and ischium. So the rami, in terms of the pubis and ischium, are the longer portions of those bones. Now, if you were palpating, let's say on yourself, just to get a sense of that pubic area, the rami are palpable, but it's too vulnerable of an area. It's too close to the sexual organ. So we're not, we're not massaging that area specifically at all. And of course that laterally rotates as well. This inserts on the trochanteric fossa. And remember, a fossa is just sort of a depression area. Questions on the obturators? Externus and internus. And now we have two gemelli. So we have a gemellus superior and a gemellus inferior. And I would say these are way too hard to actually specifically isolate. Of course, their action is laterally rotate the hip because all 6 of these muscles do that. Let's take a look at the differences in the origin and insertion. Gemellus superior is the ischial spine. There's such big, strong glutes in the area that is very deep, and I would say not that you're going to isolate it. And then the medial surface of the greater trochanter is the insertion. That's our gemellus superior. And then our gemellus inferior is ischial tuberosity, which is all the way up and around the corner of it. This is very deep in this region to the glutes. And then it inserts on the medial surface of the greater trochanter. And again, I would say that it is very useful to work your way all the way around the greater trochanter, and you will feel tight spots and work those out, but very difficult to isolate, is this gemellus superior, is this gemellus inferior, so forth. And of course, those rotate. So just as a review, all 6 lateral rotators do rotate the hips laterally, as is in their name. We've got 2 gemelli, superior, inferior. We've got 2 obturators, internus and externus. And then we have our piriformis and our quadratus femoris. Are there any questions about the deep 6?
No questions.
Okay, thanks for speaking up. I'm going to pause the recording. So for today's sculpting, we're going to sculpt the deep lateral rotators of the hip, the 3 gluteal muscles, and optionally, it could be helpful to sculpt the sacrotuberous ligament and sacrospinous ligament. Obviously, it works best to sculpt the deeper structures first and then the superficial structures. If you have a bilateral model, I recommend sculpting the deep 6 on one side and the glutes on the other side. If you are sculpting just on one side, make sure you take pictures of the deeper structures, such as the deep 6 and Gluteus Minimus, before you cover them with the more superficial structures. I recommend using different colors for each muscle, but that's optional. And remember to label your work at the end. All right, I decided to sculpt my sacrospinous and sacrotuberous ligaments before I did my deep 6. So here's the sacrospinous on this anterior view from the sacrum to the spine. In the hips or os coxa. So I'm doing my ligaments here in purple, and from this anterior view we can see sacrospinous in there. And now I'm going to go posteriorly to build sacrotuberous. And now for the sacrotuberous ligament, very big, strong ligament, like a big Y-shaped ligament from the PSIS to the base or the apex of the sacrum. And then above, on the ischial tuberosity or the sits bone, but above where the hamstrings would be here. In fact, you could see the hamstring tendon and how it would connect in there. So on the posterior view now, we've got this big, great Y shape in purple of my PSIS, my ischial tuberosity or sits bones, and the apex of the sacrum. All right, I'm building my Obturator Externus next. So on the anterior view, covering this foramen or the holes there, and then going behind the neck of the femur to attach on the greater trochanter. So three-dimensionally, here we have it in yellow on the front view. It's a little thicker than it would be in the body, but it was difficult to build. And then a great thing about the three-dimensionality of sculpting is you can really see, you know, when we go behind structures and then tuck in behind. So there's our externus. I'm going to do internus next. That's obturator externus. Okay, so next I built obturator internus in red. So here we are looking at a posterior view, and it would be on the inside of attaching or originating on the inside of that obturator foramen, those holes, and then it's going to attach to the trochanteric fossa, next to the greater trochanter. And so in the model in the posterior view, in red here, we have internus, and turning the corner, this tendon would be a lot smaller, but it's hard to sculpt. And then internus here we have in yellow, and these would become a continuous tendon here. So I could, sculpt it in the same color, but it's a little small to do that. So the gemelli, superior and inferior, they're very thin, very small muscles. So I'm rolling out some very thin muscles, and I've reflected the sacrotuberous ligament to get the gemellus superior here on the spine, and then going up to the top here, a little more anterior on the greater trochanter. So that's the gemellus superior. And then gemellus inferior, tucked to the origin, just inferior, just below gemellus superior. So I'm doing this inferior in pink, so below the spine. And it would be a little thinner than this, but hard to sculpt. And then I'm going to put my sacrotuberous ligament back. So here we have gemellus superior here from the spine to the medial surface of the greater trochanter. Very small, very deep, shared shared tendon on the insertion. And then here we have the gemellus inferior originating just below or inferior to the spine, and the insertion on the medial surface of the greater trochanter, just a little bit below superior. So there we have gemellus superior, gemellus inferior, and in clay, I've got them here in green and pink. And so then refresher there, the obturator internus here is in red, and the obturator externus here is in yellow. And then the last two I'm going to build are actually the most palpable ones. I'm going to build piriformis and obturator externus next. Okay, so now I've sculpted piriformis, which is actually originating on the anterior surface of the sacrum. So I just kind of tucked it under there. And then the most superior of these tendinous attachments here, of these deep rotators. And here it is by itself, and here it is relationship to the other rotators. So in my sculpting, it's here in blue, and I try to, attach it to the anterior surface of the sacrum, and there we have it on the greater trochanter, and then I'm going to put the sacrotuberous ligament back like so. And it's not really obvious from the sculpture, but when you're actually palpating, this blue piriformis is bigger and actually quite discernible by comparison to these other gemelli and obturators. Okay, then my last of my deep six is the obturator internus here, I'm sorry, it is not my obturator internus. I'm going for my quadratus femoris is my last one. So here on the lateral aspect of the ischial tuberosity, and then we're going into this intertrochanteric area. So, and that one's very palpable. So here it is in orange on my lateral aspect of my ischial tuberosity. And here we are below the other deep six insertions. It's lower. And I was going to pop in a little, see if I can pop in a sciatic nerve. I'm not going to do the entire length of the sciatic nerve, but I'm going to try to get it under this piriformis, just as an indication of, where this sciatic nerve would emerge. Maybe I'll just remove my piriformis and actually tuck it under there. And hopefully that sciatic nerve is not an impingement problem, doesn't have an impingement problem for this person. And that's the deep six lateral rotators. And I think I'll build the glutes on the other side. All right, I sculpted Gluteus Minimus first of the glutes because it's the deepest. And here we have a pretty broad origin on the gluteal surface of the ilium between the anterior and inferior gluteal lines. So you can see it going pretty far anteriorly and more inferiorly than medius as far as the origin. And then you have to look at the anterior view to see that it inserts on the anterior aspect of the greater trochanter. And here we have the fibers up here. So in my model, I have it on the, going more to the front of the ilium and inserting on the front of the ilium. And there we have it in green. All right, so next I sculpted Gluteus Medius, which the origin here in gray is just below, all the way just below the iliac crest, very far anterior to pretty much right where it turns the corner, the iliac crest. And then it goes to the lateral aspect, inserts on the lateral aspect of the greater trochanter. So right here, and all these fibers converging. So on my sculpture, it's in pink, and it goes all the way in this anterior aspect to this posterior aspect, and we'd have kind of a fanning of the fibers if I were to draw those in. And you could see where it covers Gluteus Minimus in green. Okay, the last glute, Gluteus Maximus, the largest gluteal muscle, originating all the way from down the border of the coccyx, the sacrum, the entire lateral border of the sacrum there, and up into part of the iliac crest. And inserting into the iliotibial band or iliotibial tract, two names for the same thing. I did not sculpt an iliotibial tract, so I just sculpted going into the bone basically. But it does, the lower fibers do insert into the gluteal tuberosity here. So in my sculpture, I've got my Gluteus Maximus in red, again, all the way down from the lateral border of the sacrum, coccyx, sacrum, and the top of the ilium, just below the ilium. And then we're going down to, there would be an IT band here, and then the gluteal tuberosity. Okay, and then just a last quick little tour here through the labels of my 6 deep lateral rotators. Here in blue, we've got Piriformis, and then in pink, well, here in green, Gemellus superior, and then in pink, Gemellus inferior. And this one here that comes around this inside and around the corner is Obturator Internist. And what you cannot really see in yellow coming around the outside is Obturator Externus. And then here in orange is Quadratus Femoris. And then here coming out from underneath this Piriformis is the Sciatic Nerve. And then here, the large posterior Gluteus Maximus here in a dark pink or red. And here we have Gluteus Medius in pink. And then underneath, if we peeled that away, you could see in green Gluteus Minimus. The 3 glute muscles and the 6 deep lateral rotators of the hip.